opportunity to just highlight certain recent advances in management. And We recently had this INASL ERN 2025 guidelines published. So I have also included parts of these guidelines and certain other recent advances which I thought are worth mentioning. So it's not going to be a kind of a lecture on managing Wilson's. It will be what is new in managing these patients and what all can be applied in future. So I'll start off with genetic testing. We know that we follow the Leipzig score for diagnosis. We have come with a modified Leipzig score, which we published in 2019. And these are really based on copper, ceruloplasmin, and various other parameters which you are familiar with. Now, genetic analysis has become more common, and it is the single gene testing of the ATP7B gene which has been recommended. So, if you have a strong clinical suspicion based on the symptomatology and the copper studies that this is likely to be Wilson's, you would just want to study the gene and not the whole exome. Now, if you do not get, you need to get either a homozygous state where you have the both variants. We refer to mutations as variants now, where both variants are there, either same when it is homozygous, and when they are different, they are compound heterozygous. So if you do not get a variant, or if you get only one variant, then you may want to do further studies to look at deletion and duplication, which is also there in these patients and may not be picked up on the single gene testing. Family screening. Now, why is it important? If you look at the INASL 25 guidelines, they say that the genetic analysis should be part of the diagnostic scoring, but should follow other tests. So even if you have a confident Leipzig score of more than equal to 4, even then you need to go ahead with a genetic analysis for confirmation and also to screen families. Now, how do you screen? For siblings, you do the genetic analysis. For parents and children, if the genetics, you will do it only if the copper tests and the liver function tests are normal. So then you'll go ahead and do a genetic analysis. Otherwise, you need not do a genetic analysis because the risk is extremely small, 0.5%. It is also used to diagnose. So there's no other tests which can diagnose newborns. I'll talk about another new test which has been used. But genetic test is one of the tests which can be used to diagnose a newborn or an infant with Wilson disease. This was a nice paper published in 2020 where they described that so far there have been 907 variants of ATP7B. When we studied, it was 200 variants. Now it's become 907, and I'm sure after 2020 there have been many more. Now it looks at the, do we have a pointer? No, we don't. Okay. It looks at the Indian variants also, and you can see even within India, between north, south, east and west, it's all very heterogeneous. So and that is really the problem in Wilson's, where we've still not been able to establish a genotype-phenotype correlation. Now, what is free copper? It is the non-ceruloplasmin bound copper, and this is the copper which causes organ damage. This is normally calculated. In the West, you'll find it being calculated based on serum copper and ceruloplasmin, and this is what is used for following up patients of Wilson's disease to see whether they are adequately decoppered or not. The problem is that in India, ceruloplasmin is measured by immunological methods and not by the enzyme assay, and this overestimates the ceruloplasmin and gives an inaccurate free copper value. And therefore, we do not use free copper in following up patients. We typically use 24-hour urine copper. Now, there are two entities, and these are important and new, though this was described much earlier. Exchangeable copper. It offers a view of free copper overload, and it is measured by the atomic absorption spectroscopy, and relative exchangeable copper, which also estimates the free copper, and it's a ratio of the exchangeable copper to the serum copper. Just to explain it further, what is exchangeable copper? It is measured by adding EDTA to the serum. Now, EDTA is a copper chelator. It binds with copper, and the EDTA bound copper is measured as exchangeable. So whatever copper binds to the EDTA is the exchangeable copper. And there are values of more than 2.08, which is thought to be significant. However, it is found to be more useful in extrahepatic involvement in Wilson's and not so much in hepatic involvement of Wilson's. And Balki et al. In the year 2011 showed that the relative exchangeable copper, which is exchangeable upon the total copper of more than 18.5%, could diagnose Wilson's with a sensitivity and specificity of 100%, which was fantastic. So it has been used to diagnose asymptomatic siblings of patients. It's a very easy test. You don't have to wait for a month or more to get the genetic analysis. It is also useful in distinguishing asymptomatic from heterozygous or carriers. And this is a large French National Reference Center study where they had 778 subjects, 204 with Wilson's, 359 heterozygotes, and 215 controls, where they measured relative exchangeable copper and they defined various cutoffs. And they said that if the REC was more than 14%, it had a very good sensitivity and specificity of above 95%. Specificity was almost 100% also over here. It was validated in both adults and children, and cutoffs were established. So they said the reference range for exchangeable copper was 0.5 to 1.38, and for REC was 2.6 to 9.5. So anything between 9.5 to 15 or 14% was in the heterozygous range. Below 9.5 was normal, and above 15 or 14 was suggestive of Wilson's disease. So this is what the INASL guideline also says, that look at, this is the first guideline which has included relative exchangeable copper in the diagnosis of Wilson's, and they've used a cutoff of 15% with a level of evidence to strong recommendation and strong consensus. This was a meeting which was held by the Delphi consensus. What else? So in our guidelines, we talk that liver copper estimation in India is a problem. And due to various reasons, the method is not well standardized, the way it is collected, there may be more fibrous tissue, etc. Now, this is a new test. Again, I heard about it yesterday in Dr. Sanjay Kakkar's talk. He talked about metallothionein immunohistochemistry with a high sensitivity and specificity. So instead of using rhodamine, use metallothionein, and it had pretty good specificity of 96.9% and accuracy of 94.9%. However, in non-fibrotic patients, the sensitivity was lower, and also zinc treatment may give a false value. So this was good when you were seeing the patient for the first time, not sure, wanted to do a liver copper, but instead it was compared to metallothionein and was found to be pretty good. So quantitative liver copper, as I said, higher cost, longer turnaround time. For us, standardization is a problem, not easily available. If this immunohistochemical stain is available, it will be a good alternative. There are other tests for KF rings. We know that slit lamp is a very subjective test. You need very experienced people to look for KF rings, especially when the patient is very jaundiced. They are often confused for bile pigment rings. So this is an anterior segment optical coherence tomography, or ASOCT, which has been used, which is much more objective. And there's another test called in vivo confocal microscopy. Again, it is supposed to be very sensitive and can pick up very small amounts of copper. Here you can see in the first panel here, if you look at it horizontally, A to C, this is a patient with strongly positive KF rings. This is the KF ring here. We don't have a pointer. And in the B is the confocal. I'm trying to use, but it's not working. Okay, let me see. Does it work now? Yeah. So this is a slit. No, but it works temporarily. Okay. So this is a slit lamp. This is the in vivo confocal microscopy, and this is the ASOCT. So this line here, a hyper-reflective line, is the KF ring. This is where the KF rings were borderline positive. So it's not so well seen here. And here you can see it different pattern on the IVCM, and this is the ASOCT. And this is a negative KF ring where none of this is appreciated. So again, I think this is a little more theoretical. ASOCT can be done by the bedside is what the literature says. But when I spoke to my ophthalm friends, they said it's not very easy to do it by the bedside, and I'll want experience of people if they have used this in their clinical practice. Okay, this is the next test, ATP7B peptide analysis, and this has been tried again in a large group of patients, 216 Wilson disease patients, of which 211 had genetic results, 144 were genetically confirmed, and 67 where the genetics was ambiguous. And they combined the blood with the antibody to this ATP7B and used it with the patient serum, and they found that in Wilson's disease, there was absence of peptide or deficient peptide. And overall, in the Wilson's disease patients, 92% showed deficiency of this peptide. In those who were genetically ambiguous, 94% showed absence of peptide. So it was very useful where the genetics does not help. And also in those where the ceruloplasmin was normal, which can happen in 20 to 30% of patients. Again, very easy to do and has been suggested as one of the tests for newborn screening by dried blood spot samples. So where do you use? So this is a classic genetic result which you get. This patient is homozygous for Wilson disease for this variant, but it is a variant of uncertain significance, and this is where one could use the ATP7B peptide. Now there are other tests, MR tests, which have been described. This is T1, this is T2, and this is the test called quantitative susceptibility mapping, where it shows increased magnetic susceptibility in the basal ganglia. And basically, various heavy metals like copper, iron, hemosiderin can be visualized and quantified. So it is good for diagnosing, prognosis, and monitoring treatment. This is a study looking at 33 patients and matched controls. And you can see here that in this subgroup here, these are the you can see the on T2, the copper being identified in the basal ganglia, and it is quite magnified and quantified in this quantitative susceptibility mapping. Again, clinical significance, maybe I'll mention it in a minute when we talk of liver transplants in these patients. The 64 copper tagged PET study also has been used, where the isotope is injected intravenously, and then you look at the uptake. It gets taken up in all patients. So healthy patients, heterozygotes, and patients of Wilson's disease all showed a quick uptake of the heterozygote of the isotope at around 90 minutes. But what happened was that in healthy individuals, it kind of achieved a steady state. Within an hour and a half, it was excreted in the gallbladder, and at 20 hours, it was already in the colon. As against this, in patients of Wilson's disease, there was no excretion seen in the gallbladder at 1.5 hours and nothing in the colon. And you can see that it is much more dense over the liver. The SUVs actually over a period of time went up, showing that the entire copper is getting accumulated into the liver in these patients, and the liver is not able to excrete it, which is a basic defect in these patients. So again, a good study in patients where you may not be able to get a diagnosis, but not yet included in any of the guidelines. Now, switching over to, we spoke about diagnosis, management. Again, I'm not going to go through the whole standard management, but certain things which have been published recently. We know that triantine dihydrochloride is what we've been using, which was made available in our country, though it has been in the US since the as early as 1970s. But the problem with this molecule was that it had to be in a cold storage. So in 2018, the triantine tetrahydrochloride became available. Efficacy wise, there was no difference in the two. There's no head-to-head comparison with these two molecules. The advantage of the tetrahydrochloride is it is stable at room temperature, and we have both these molecules available in India. It's made a big difference because maintaining a cold chain is difficult. It's more rapidly absorbed and higher bioavailability, but again, not compared head to head, and also more importantly, it's a cheaper alternative. So triantine tetrahydrochloride is something that we can use. Especially we restrict this to patients who do not tolerate penicillamine. For us, penicillamine is still the drug of choice. Now there is this trial. Now this is a common question asked, whether trientine has been compared to d-penicillamine. How do the two compare in terms of efficacy and safety? So this was by Michael Shilsky from the US, where he took patients. 27 patients were randomized to penicillamine and 26 to trientine tetrahydrochloride, and they found that the expected is it time up? Time is up. You have to conclude. Okay, so I'll go on. So basically, no difference in the two. Same with tetrathiomolybdate, a new molecule, not a very new molecule. In fact, studies date back to about 2 decades earlier, but still there are phase 2 and 3 studies which are looking at these molecules, and especially the choline equivalent. This is promising because it's supposed to be better with neurovilsins, though it can cause LFT abnormalities, and there is a hitch in using it in patients who are having liver disease. So monitoring, I spoke about early neurological deterioration. Just a word that it is not only for penicillamine, it's very much seen for trientine, though lesser number, and also for zinc salts, which is even lesser. And there may not be complete resolution of the neurodeterioration. And this neurodeterioration may not be only in the neuro patients, in a very small minority of hepatic patients also neurodeterioration may be seen. Now, this is one thing I just want to emphasize on plasma exchange, therapeutic plasma exchange. We know that we have been talking about the new Wilson's index or the modified King's College scoring to determine which patient should go for transplant. But this study from ILBS showed that in those who had, they took 96 patients and subjected them to therapeutic plasma exchange, and they found that the survival of the native liver was very good even in those with a high new Wilson index of more than 11, and one could escape transplant, and it was improved threefold after 3 sessions of plasma exchange. So one may consider therapeutic plasma exchange before sending them for transplant, though INASL still says that even in patients who do not have encephalopathy, if the new Wilson's index is more than 11, then it becomes an indication for transplant. So we really need to validate this and see this. Just a word on neurovilsons, even severe neurovilsons without much of liver disease, what is called the brain indication for transplanting, can be considered, but I think we really need to look at this, because I can't imagine a patient who is bedridden, hardly able to move, dystonic, being able to go through the transplant. What they've found is there is a high risk of septic complications in this patient, and the survivals are about 5-10% less than the other population in this subset of patients. Gene therapy has been tried, and the first effective gene therapy was in 2023 in a human, and we look forward to further gene therapy, which will actually be the real cure for Wilson's disease. And there are several future directions. I'll not go into this. And I would just, again, here, I would say this is you could refer to the INASL 2025 guidelines, where they, I want to show, have added relative exchangeable copper in patients who have low Leipzig scores. And if this was more than 15%, one could straight go for therapy. And as I said, molecular testing was emphasized even in those with definite Leipzig score showing Wilson's disease, go ahead. And in those, they say that if the Leipzig score is not more than 4 or equal to 4, go ahead with liver copper. Now, as I said, this is a problem for us, and maybe metallothionein IHC in this patients may help. And for the Leipzig score, we have modified it because we do not want to add liver copper with our limitations. So one could use the modified Leipzig score to decide whether to go ahead with molecular testing or not. And finally, I would like to end the talk by showing you a picture of these 3 siblings of a child, 10-year-old child who came to us with fulminant liver failure, could not be saved, was listed for transplant, could not be saved. But the 3 siblings were screened. And I think it's really, really important to screen siblings. And unfortunately or fortunately, all 3 were positive, but all 3 were pre-symptomatic. They are about 5 years follow-up, and they're all doing well with normal LFTs. Thank you. You can take the seat there, and we can have the second lecture. May I invite Dr. Sadhana, and she is the professor and head of pediatric gastroenterology at PGI Chandigarh.
Thank you for the introduction. It is actually pediatric gastroenterology and hepatology.
And liver transplantation also.
Hoping to get into soon. I mean, on the way. And I think we can see a lot of familiar faces. So, good evening to all. And with that, I mean, I don't think I need to thank anybody because I don't see any organizer here actually. So, so I have been given the task of talking about recent advances in inherited cholestasis over the next 15 minutes, and you can understand that's a tough call. So, when we talk about novel drug development in cholestasis, uh, we have to think of candidates which are not only going to restore the bile flow but also prevent the regurgitation of bile acids and pruritogens into the bloodstream, also restore the fat metabolism and correct the deficiencies, remove the dependence on MCT and fat soluble vitamin supplementation. Thanks to all our basic scientists, our dear colleagues, we now understand that the key culprit in cholestasis are the bile acids, the enormously high levels of which in the hepatocyte not only cause a direct deleterious chemical detergent action, but also they are signaling molecules which increase apoptosis and cause mitochondrial damage, releasing reactive oxygen species, ER stress, all of which serves to release DAMPs, which serve to recruit the pro-inflammatory cells and cytokines, ultimately culminating in fibrosis and cirrhosis. And something similar happens in the cholangiocyte also, which are the function of cholangiocytes being also dependent upon the amount and the nature of the bile acids there. They tend to badly damage the protective bicarbonate umbrella. So another thing which is very closely intertwined to drug development and advances is an understanding of the enterohepatic circulation and regulators. Now we know that we have the FXR and the FGF19, which are involved in the controlling the synthesis of bile acids. We know about the importers, the exporters, the various receptors which help in the import and export of bile salts, and we know about the ileal transport regulation. Because of this knowledge, a number of candidate drugs, because we've got smart pharmacologists, so there's a number of candidate drugs have emerged. I'm not going to enumerate all of them, but it would suffice to say that most of these drugs which hit the various pathogenic pathways are not relevant to children really, because most of them have been tried in adult cholestasis. As far as the pediatric literature is concerned, we only are majorly concerned with the apical sodium dependent bile acid transporters, which are present in the ileum and the inhibitors of these receptors. So in addition, there is some knowledge on chaperones, and the rest is actually a matter of experimental preclinical studies. Now, coming to the ASBT, we all know that normally less than 5% of the bile acids are excreted because of reabsorption at the bile salt, which is a function of the ASBT. So, ASBT inhibitors prevent this reabsorption, thereby reducing the amount of bile acids which enter the portal blood and are exposed to the hepatocytes. So, in a sense, they reduce the bile acid pool by depleting the body of bile acids. So, this obviously would not work if the cholestasis is severe because of a severe mutation, because no bile would be excreted. And also, we have to remember that once less of bile acids are absorbed, the FGF19 and the FXR and pathways will also perk up and cause an increase in the synthesis of bile acids. So, it's not all that simple. So, however, we know from the NAPID experience that about there is a fraction of patients, especially of PFIC, which respond to surgical diversion. So, ASBT inhibition, in a sense, would be equivalent to a medical diversion, would cause the same effect without the attendant morbidity of surgery. So, a number of agents have been investigated in pediatric and in Alagille syndrome as well as PFIC, and the result of these trials have been that there is a conditional approval of maralixibat and odevixibat only for the treatment of pruritus in PFIC and Alagilles in children. Now, if we have a look at the studies of ASBT inhibitors in Alagille syndrome, we started with the iconic the Imago Imagine trials. Now, these are trials of maralixibat in the disease with their long-term open extension arms. Now, what we find, the major issue is that the numbers are very small, white here. Numbers are small, and several of the studies, the primary outcomes, which were majorly a reduction of the Ichiro score by more than 1, or a reduction of the serum bile acids, which, mind you, in several of these studies was not taken as the traditional at least 70% reduction from baseline, but even 50% was considered as a response. So even these primary response were not measured, were not met in the early part, that is up to 18 weeks, 13 weeks. So as with the extension, however, there were some favorable results, but at the cost of a lot of adverse events. Admittedly, none of them were severe. Up to 50% of the patients suffered from diarrhea. What was a little bit alarming was that about up to 15% of these patients on these drugs also had elevation of the LFT, and in some in this report especially, the Imagine 2, there was also a reduction, prolongation of the INR mild, and reduction of platelets. So this raises a little bit of a question mark. Some of these studies have also monitored the autotaxin levels, which is important to have an objective assessment of pruritus control, and also the C4 metabolites, which give an indicator of the production of bile acids as such. Now, the PFIC trials range from the Indigo to the PEDFIC-1-2 trial, which tested maralixibat, and the March and March On trials, which tested odevixibat. Again, numbers are small, but it was very clear again from these studies that about a third only of the patients are going to respond to these ASBT inhibitors, at the cost again of elevated LFT, reported here in up to 80%, though no serious adverse events were noted. So, since they have been around for a long time now, the predictors of a 6-year event-free survival for ASBTs inhibitors in Alagille syndrome was looked at in the 4 earlier studies that I had mentioned earlier, the ICONIC, the Imagine, and the Imago Imagine studies. Now, they picked up the variables which had a C statistic of at least 0.7, and they concluded that at week 28, if the Ichiro had reduced by more than 1 point, if the TSB was less than 6.5 and the serum bile acids less than 200 micromole per liter, then this could predict an event-free survival. They also reiterated what we already know, that young children below 3 years itself, that is itself a poor, going to be a predictor of a poor outcome, and we know that these kids have got a poor natural history from the GALA study. They additionally looked at the number of protective variables present. If a patient had all 3 protective variables which were present, then the survival was 91%. It went down to 87% for 2 present, 51% for 1 present, and 33% if none of the protective variables that I mentioned earlier were present. So obviously, the study, the average bile acid levels and the bilirubin levels were much lower than what we see in real life. The bile acid response was also lower, 50%, not the traditional NAPED recommended 70% at least. There was no placebo arm, so the effect of the natural history of Alagilles cannot be assessed. It was a trial scenario, and we now are again. It reaffirms that possibly there's no use using these drugs in the younger infants. So when we talk of the question mark on the natural history contributing to the disease, this recent study came up from Italy, a small experience of 24 children, with most of them, 2/3 of them had the classic PFIX, with a 6 months follow-up. And what you can see is that the bile acids went down in the first 6 months, as did the H scale. The H scale also improved, and at the end of 6 months, far more patients had none or mild pruritus as compared to the baseline. 75% of, this response, as you can see in the responders, was mostly in the early phase. 75% of the patients had response in terms of bile acid, and 30% of these required escalation. 25% were non-responders, and in them protein truncating B-sub mutations were present. Mild elevation of the LFT happened, which did not necessitate dose adjustment. Then an extension of the NAPID cohort, which beautifully showed us that if the child has a mild mutation, the child is going to drop his or her bile acids by more than 70% and will do well on surgical diversion. So they decided to look, the same group, a cardiac group, they decided to look at whether if there was a combination or there was a homozygous mild mutation, homozygous for truncating mutation, and in between, if there was a compound heterozygote with one mild and one protein truncating mutation, would that give any benefit? And they found that it did not. So the upper line is the mild homozygous, and the lower two are the compound heterozygous and the homozygous for the truncating mutations, and these are having an equally dismal prognosis. Reaffirmed the fact that those patients who dropped their bile acids by more than 70% had 100% native liver survival, as compared to less than 40% in those who did not do so. Also, importantly, another finding of the study was that the risk of HCC was much higher with the patients who were homozygous for the protein truncating mutations, and this risk was not translated into the compound heterozygote group. So this brings us to the next group of drugs, the chemical chaperones. 4-phenylbutyrate, has been used for urea cycle defects, and it has a potential for cholestatic disease because it can enhance protein folding, and which can result in the increased trafficking of BSEP and FIC protein to the canalicular membrane. There are 3 or 4 case reports which mention this beneficial effect in patients with missense mutation. These patients had a decreased expression on the canalicular membrane, but otherwise the functionality of the protein was retained, and they found that with the use of the drug, the expression improved on the canalicular membrane, as did the LFTs, the histology, with no severe adverse events over 40 months. Though a little bit of a worry, because earlier reports with alpha-1 antitrypsin deficiency have shown some significant side effects with the drug. Then CFTR potentiators like ivacaftor and the other new ones, they have also been used entirely in preclinical studies, in which the reverse was true, that the molecule, the BSEP, was appropriately localized to the canalicular membrane but was dysfunctional. That means the transport function was low. So these patients in these Hep G2 cell lines corrected this functionality, and this seems to be, there may be some hope in this molecule. Then, very interesting, we know the drawbacks of the ileal bile acid transport inhibitors, that they are going to be dependent upon the type of mutation. If the mutation is severe, nothing is going to happen. And moreover, there's going to be a rebound increase in the bile acid synthesis. So the systemic IBAT inhibitors work not only in the ileum but also on the biliary acid transport receptors, which are present in the biliary tree and in the kidney. So, preclinical studies in CB4 knockout mice were quite attractive, because they resulted in improved LFTs, increased urinary and fecal excretion of bile acids, and even a phase 1 dosing study in healthy volunteers has been done. Another recently published article tells us that, as we talk, that there is a rebound increase of the synthesis of bile acids because with the use of ASBTs. Now, very smartly, in mice model, they have they have tested ASBT alone versus ASBT with the obeticholic acid or cilofexor, and in another arm, ASBT with aldafermin, which is a FGF19 mimetic. And they found that in these two groups, the combinations, the responses were much better. So again, some food for thought, and maybe something for the future clinical trials. I'm not going to go into gene therapy. Dr. Dhawan is going to go into the details of it, so I'm going to skip that. So to conclude, the drug part, at least there are numerous exciting insights into the pathogenesis, and these have translated into immense therapeutic possibilities. However, novel drug development has got its inherent problems in the context of inherited cholestasis, because these are ultra rare diseases. Placebo arms are unethical from patient, parent, and regulatory body perspective. Randomized controlled trials are impossible, nearly impossible. And moreover, the response to drug is mutation specific, which further reduces the numbers to which a particular drug can be applied. For the future, maybe because RCTs are not possible, patients may become their own controls, and sequential drugs may be tested with a washout period in between in the same patient to give us an idea of the efficacy. Also importantly, the effect of the drug on disease progression remains unclear. So ASBTs are not they are advocated only for pruritus. It is difficult to tease out the role of the natural history, genetic factors, placebo nocebo effect from the positive or negative drug effects. It is difficult to determine drug hepatotoxicity in the injured liver. The long term safety data is the last word has not been said. We do not know what is the effect of supraphysiological levels of bile acids in the colon for years and years together. Also, there is bound to be some issues with the fat soluble vitamin deficiency in the long term. So, admittedly, the IBAT inhibitors can alleviate pruritus and, as per these published studies, improve the quality of life and the event-free survival. However, in the context of BSEP, they don't work in the truncating mutations, and they do not work in all the rest of the non-truncating mutations also. Overall, the response is less than 30%. So it is prudent to do the genotype to be able to tailor the treatment before prescribing these expensive drugs, which are anyway not available in India. And we have to understand the complexity of NGS evaluation. We have to be strong in our bioinformatics, and possibly we may be able to use serum bile acids and C4 as biomarkers. I think I can skip the rest of it, though it is all to do about the explosion of variants and the problems which arise thereof. So I'll straight away come. I mean, we have got patients who have got same gene and two siblings, both behaving differently, and we have got patients in which there is only a heterozygous positivity of the gene, and they behave poorly, possibly indicating that these genes can also help to modify the behavior of commonly known disorders. Now, this is our experience, which I'll definitely skip in the interest of time. So we have to be very sure that we make a good clinical, pathologic, biochemical, and genetic correlation. Don't blindly do the genetics and leave it at that. So, in the face of lots of genetically unexplained specific phenotypes, we are armed with a good knowledge of the pathogenesis. We are armed with the availability of high throughput, cheap NGS, which has resulted in an active search for variants in the pathways of the bile acid transport and regulation. This has led to the discovery of newer and newer disease associated variants. People have taken help of the in silico prediction models, the bioinformatics to confirm or negate the variant pathogenicity, and this has resulted not only in newer and newer PFICs but in a lot of new cholestatic diseases. So we should test, but test prudently, so that we don't end up with uninterpretable data. We should be sure of our clinical phenotype, and we have to be ready to deal with the emerging issues, not only of genetic counseling, but also various ethical, legal, and insurance issues come up once we are faced with such a lot of variants. Thank you.
Please take the seat. Speaking on the topic. Thank you very much.
Thank you, Surinder. And while the slides come, it's very opportune that slides are not there yet. May I take this opportunity with your permission to honor Professor Walia?
Yes.
Those of you who don't know, Professor Walia was a professor of pediatrics at PGI Chandigarh. Professors were scary those days, and maybe they are not there anymore, but they used to be very, very scary. But this gentleman had a unique character that he will relate to the residents. Coffee morning was must, and barfi, talwar ki barfi and chai was must. And that's where he opened up. And what did I learn from him? 4 things rather. I learned from him is, when you see a talent, spot it, acquire it, and make it flourish. Don't let the talent go waste. That's first thing I learned from him. And what I delivered on that is at least 16 of my trainees and so-called fellows are currently heading the very prestigious departments in pediatric gastroenterology, hepatology from North America to Australia to Singapore, Middle East. That was one. Second thing was government money is not always enough. State-owned money is not always enough. If you are good, okay, people will reward you. And what I learned from him is philanthropic support. I saw his dedication toward Karuna Southern. If PGI people know here, they will know where Karuna Southern is. Karuna Southern was a place for neurorehabilitation children. We all hated it because we wanted to be experimental people and who is going to sit there. He spent time with Rotary Club. And when I followed him, and I got an opportunity to follow him because I used to take a slide case to show up. Those days there was no automatic thing, so you have to put one slide at a time on the projector. What I learned from him is how he convinced people to donate money. And I've continued that tradition, and my laboratory is predominantly supported by massive philanthropic support from multimillionaires and billionaires from the eastern coast of America to Europe. And those kind of things which I learned from him. And last I will say is, although I'm very touched, very excited, but अगर चेला के गुरु की सभा में प्रवचन कर रहा हो तो चेले का नर्वस होना बहुत obvious है. So if I get nervous, thank you very much for that. So in the next, now I've taken maybe 2-3 minutes, but grateful that you didn't count it. So over the next 12-15 minutes, I'm going to take through a little journey where we are heading. Okay, we are heading to the era of regenerative therapies and gene therapies. I think that is going to be the future. Our next generation is going to laugh at us. These people used to change the whole liver. Look at how crude they were. When the liver is the most regenerative organ in the human body, and why do they need to change it? Now, some of you may have seen this slide, but this is a slide of Prometheus. Prometheus was a demigod, a Greek god, who was not supposed to teach humans how to make fire, but he did. But his fellow gods, he gave all the powers to humans, so he should be punished. The punishment was that he will be chained to a rock. So if you see that chain on his wrist, and this vulture will come because they opened his abdomen, chained him to rock, and his vulture will come and eat his liver away, and he will die. The story goes that he didn't die because his liver kept regenerating. Now, if it hasn't occurred to you, liver is the only solid organ in human body that regenerates, other than bone marrow, which is not a solid organ. Okay, if you do a partial hepatectomy like a living donation, after 3 weeks, 87% of your liver is back. Okay, now can we harness this potential of the liver in the 21st century? Okay, one example is acute liver failure, where patient has one-time insult. Somebody taken paracetamol, one viral insult. Can that theory of Prometheus work? Okay, in this human experiment, this is a human experiment where part of the liver has been removed, and the removed part is replaced by a donor liver. So let the donor liver work for a few weeks till Prometheus liver starts regenerating. So what you see here is this journey over a year of this patient. When he first presented, we did a HIDA scan. We show no excretion in the patient's own liver. Everything was the donor. Fast the film forward, you see there are two livers. In between, we reduced immunosuppression, take it off, liver biopsy representatives. What it means is, liver, if supported for a few weeks, in acute liver failure setting, can regenerate. Okay. Then the question is, how low is low? Is that much liver is enough, or you can go low? So we, in our lab, it took us 15 years to develop a system where we can put liver cells into allogeneic, which is non-allergic or non-immunogenic, and rescue these patients from liver transplants. Not all, 50% got rescued. but it also tells us that we may be over transplanting patients. When somebody come to acute liver failure, next question is living donor tomorrow transplant. So I think we do over transplant, and they may have got better. Now, if you have a metabolic liver disease, which is lifelong, then can you do? We believe that liver has a lot of redundancy. It has more enzymes that we need. So take that knowledge into account, and if you only give them a part of a liver, then the phenotype will change. They will become homozygous to heterozygous, and symptoms will go. So in this experiment, part of the liver has been replaced. Example here is Kigel in a jar, and that's the reason I'm showing Kigel in a jar, because I'm complete the story later on. See that patient's bilirubin normalized. This is the explant, this is the native liver, this is the native liver, this is the graft, and this patient are happily living with 2 livers but no jaundice. Then question came, in metabolic liver disease, how low can you go? Again, like liver failure. Okay, do you need that much liver? So question was, can you get away with cells? And cells is, can you infuse the liver cells into the liver? Some of them will stay in the liver, not all of them go away. So with this experiment, when we did this in these Krigler patients, just remember this graph where we demonstrated that you can reduce the bilirubin by 50% and reduce the phototherapy duration by 50%. They did not get jaundice free, and that's what these patients wanted. Okay, so our experiment worked, that it did help, but it didn't cure them, and that's what they wanted. So they opted for the previous treatment, which is auxiliary transplant. At least they were not jaundiced. Now I want you to remember this graph because relevance will come. Now, where are we going forward with liver cell therapy? Because we need, there are organs. Cells don't live alone, they need more cells. So we are developing organoids, and there are many groups developing on it. And my group, who is developing now, this is not slide made by me, this is Jessica. So employ smart people. And what she believes is that what we have achieved so far is just getting one therapy for acute liver failure. What Jessica is looking at is, can she develop bioprinted organoids to look at many facets of liver disease, not just acute liver failure, but even repopulating livers of biliary atresia after transplantation. So the answer he question, the point taken here is that if you appoint smart people with you, you will get better outcomes. So this was the story of cell transplantations. While the cell transplantation has goes ups and down, it has not a standard of care at the moment anywhere. It's all research tool. Can we do different? Gene therapy, when I was a medical student, we used to hear that gene therapy is around the corner, and that has taken about 40 years, that corner has come. But now I'm so excited that gene therapy has really landed. Okay, it has its problem, which we will discuss, but I think it will become the mainstay of treatment as we go, for particularly for liver-based single gene defects. Why liver? I think liver is an ideal target for gene therapy. Look at the vascularity of this organ. When you put the genes, they are going to go there. Okay, liver has tolerogenic properties. Okay, it's easy access to give it. Okay, liver has got so many metabolic disorders that are based in liver, so you can address all those. So liver is no doubt an interesting organ to deal with. Now, how can you give gene therapy? Either you do ex vivo gene correction, taking the cells out. So our technology of liver cell transplantation that is there will have some value, because when you want to do ex vivo gene therapy, you need cell culture technology, the systems that we have kept in place, put these cells together and put them back. Mostly people are going for in vivo, which is injection of transduced cells. How do we do it in vivo? And how do you take these vectors, in other words? So delivery systems are viral predominantly. Non-viral are becoming more and more attractive because there are problems with the viral things. What can we do? How can we change our genetics or genes or genome? We can do gene editing, means you go and correct what is missing, like a what you call the word processing. You made a spelling mistake, you go back and correct it. Gene addition, gene is missing, you add that gene. Okay, gene silencing. So there are two kinds of problems you see in metabolic defects: gain of function and loss of function. Most of things are loss of function. But there are conditions which have you need to silence the gain of function, like alpha-1 antitrypsin, where abnormal protein is produced that needs to be silenced. So that's gene silences. mRNA therapies, I think everybody knows about how to change the course of COVID pandemic. Now, how can you do gene addition? Okay, you add a wild type of mutated gene into an affected tissue using viral vectors. Okay, then depends on what disease we are dealing with. Predominantly, the workhorse of gene therapy industry at the moment is adenovirus, and that takes most of the work is adenovirus. And we will discuss why adeno and adeno associated viruses are very, very relevant. And then is the lentivirus. Gene editing, most common technology that is taken now hold is CRISPR-Cas technology. ZNF and talons are not in fashion, but CRISPR-Cas technology is. mRNA therapy produces mRNA which are regulating everything, and gene silencing could be done by various different technologies, which I'm not going to go in details. Why AAV is a preferred vector? I think it's a long safety profile. The most important thing is it doesn't integrate into the DNA. So it is episomal thing. Episomal means it will not change your havoc with your rest of the genome system. That is a kind of a problem for pediatricians, because when the cells divide, that function will go down as well. So all the data that I will show you later on gene therapy is in adults or grown up or not children, because that's where the success lies. But in young children, when the liver is replacing itself every 2 years, this therapy won't last. So as I said, gene expression lost on cell division. If you have AAV antibodies or a adenoviral infection, you may not be a candidate. So now I want you to come to clinical side. What has been achieved so far? So Lorenzo was my fellow in early 2000s. Now he had the department in Italy, Padua, and he published the Krigler-Najjar first data. And there are 5 patients here. What you see is after gene therapy, the response was not what we would like. So response when you see these first 3 patients is no different than what I showed you after hepatocyte transplantation. The light duration decreased, bilirubin didn't become normal. So this is 200, okay? It's 200 micromoles. That's about 15, 16, 17 milligrams. So that's still jaundiced, but there is a drop from something like 300, 400. So there is a benefit. So this gene therapy has achieved similar results as we did. Now, initially when gene therapy started, they didn't think they will need immunosuppression. So biggest criticism of cell therapy was you give them cells, but you give them immunosuppression also. But if you look at these patients, they're all needing immunosuppression. They're on sirolimus, they're on prednisolone, and they continue on that. Okay, we'll come to that. Why do you need immunosuppression? So I think these are the teething problems. They will get over this, but one time it will come back. What I'm really excited that I'm looking after 2 patients at the moment who had a OTC deficiency, and male OTC, severe one in the first few weeks of life. As some of you know how severe they are. And so these 2 patients have received this AAV LKO3 based gene therapy. Julian Bartinu is a metabolic person in Great Ormond Street who I work closely with, and my role there is to provide them hepatic support because all these patients are getting toxicity, which I will come to in a minute. But good thing is that patient 1 is 6 months, 7 months, and other is 2 months after gene therapy. They're off ammonia lowering agents. I think Abba alluded to Wilson disease. I think the problem with the Wilson disease gene therapy is the Wilson gene is very big, and to take it into it's not possible. Not possible, but not easy. Hence, the drug companies have come with some things called as mini ATP, and mini ATP is a smaller thing, but it's less effective. But it still has shown that it can change the metabolism, and only 10% of transduced hepatocytes were enough again to get the benefit that you're seeing on the right hand side. And now this is the animal data. Now the data in humans it's a problem. They started with neurological patients. So to my knowledge, 3 or 4 patients has been transduced. One trial has been halted at the moment. So they are not recruiting anymore because of the toxicity that has been seen. So it's going through those phases, but it's hopefully one day that will be resolved. So I showed you 3 conditions. Alpha Crigler-Najjar, I showed you Wilson disease, I showed you OTC. So what is the biggest bottleneck? So I always joke that animals are very grateful species to humans. So if you do research on mice and rats, they will never disappoint you. They will give you data that you can publish in Nature, Science, Lancet, you name it, okay? If you do research on pigs, they don't tell you the truth. If you do a research in monkeys, they outright lie, okay? What message is that you only need to do in the human research when you come to the humans, okay? The story here is that when these drug companies did the trials, none of the animals showed hepatotoxicity. So the drug companies were not worried. When they brought this product to humans, they found this. So there are, at least I'm aware of 4 deaths is an SMA. I'm aware of 3 deaths in DMD patients. So deaths I'm talking. I'm not talking of severe acute hepatitis that got treated. So there is a serious problem. The DMD trial has now been stopped. So why there is a liver injury in gene therapy? So this is what we see the clinical part. We get a first peak, which is the first week, then the second peak after 4 weeks. Second peak is more worrying. First peak is not so much. So you can treat with immunosuppression. And if you look at, these are the data on about 64 patients that I looked after with SMA who developed hepatotoxicity. So in the third, fourth week, it's more of a problem. If you do a liver biopsy, which is not easy to do in these patients, they are ventilator dependent, their parents are not happy, but you see all kind of a pattern, predominantly immune mediated injury, what we will conclude it. So we came at the hypothesis not that it is a both innate and adaptive immune response, and this is response is secondary to the capsid, that's where the virus is going, the genome which you have put into that, and transgene product, which is the final product. So the immunity is against all 3. So you need to tackle both innate and adaptive immunity. So what do we do? So we set up a national MDT. So I chair this every month. So all the countries patient treated gene therapy who have abnormal liver enzymes are discussed, and we come up with a common therapy protocol from one place. So some of these patients have underlying liver disease, mild variety. So we ask them to exclude all these conditions. So which is a lot of work, but these injections are 1.5 million pounds. So they can afford some more tests on it. Yeah. So what is our current approach? MDT, as I already said, we do that nationally. So now the numbers have gone down because previously we had a lot of patients who were treated. So this is a logarithm. I think it has been published. So what we do is we have a graduated introduction of immunosuppression. We go with high dose steroids and try to taper it. But if there is a poor response, then we very fast introduce tacrolimus or sirolimus. So these were the data that we produced and published in the few things when we publish the protocols now, which are by and large accepted by many other gene therapy associations. And I advise on the NIH group, which is looking at hepatotoxicity after gene therapies. So, Mr. Chairman, ladies and gentlemen, the conclusion would be that human hepatocyte transplantation is still evolving, and 3D bioprinting with organoids may have some different outcomes. Viral-based gene therapies are now become clinical, but they are far from realistic at this point. Better liaison is required between hepatologists and gene therapy providers. What you have to remember is gene therapy providers are the organ-based. There could be hematologist for hemophilia, a neurologist for neurological disorders. So there you need to work with them together, and better immunosuppressive conditions are required. I'm grateful to my group, and I'm grateful to you all to listen. And I'm again so happy today that I could have Professor Wali and the audience. Thank you very much.
We invite now some questions from audience, please. Any questions you want to ask Dr. Dhawan? Anybody? No. Dr. Abba, you have to tell us about the updated knowledge. What are the points which can be applied in Indian patients? What are those points? Please come on to the dais. Yeah.
I think as far as diagnosis is concerned, this relative exchangeable copper seems very doable. I've been talking to the SGPGI group where they have been looking at it. Maybe Anshu can tell us something about it. And apparently, Harshad told me there's an ICMR trial going on in Bangalore with NIMHANS and other two centers where they are looking at the REC. And I think that will be one important test. It is available immediately. It's not that expensive. You do not wait for genetics, and liver copper, which is not very reliable, can be done away with.
Will it replace the usual conventional tests which we use for diagnosis of Wilson's disease in India?
No. It will not replace. First of all, there's no one diagnostic test. We depend on various scores. We've spoken about these scores in various meetings. But even with those scores, sometimes we are stuck. We don't get a diagnosis. It is in that subgroup where it is definitely going to help. And also in monitoring patients to see how adequately they are decoppered, this will be a useful test. So this is one thing I would say.
No, I just wanted to give a bit of perspective of exchangeable copper. As you see, the ASLD guideline that came last year.
Yeah.
Okay, we have no.
It did not.
We don't have that.
Yeah.
And the reason is, it's only the French center. Okay, that is consistently talking about it. Rest of Europe hasn't got it. We haven't got this established in our center. And establishing it, we are told it's taking time. And I don't know when it will happen. So I think it will come one day. It's a matter of time, and SCPGI can do it. That will be fantastic. But rest. So when the person who was on the committee is very vocal, okay, I was surprised they got it into the guidelines when 90% of the Europe is not doing it. 90%. So that is there. ASLD guidelines I think are still much more pragmatic. Conflict is I'm part of that guideline group.
EASL guidelines, both guidelines.
American.
You're in both guidelines.
Yes. But EASL one was driven and they want to promote for good reasons. It's a test. If you can get it, yes, it does answer. In my experience, when I've done it from Paris, when I've sent the patient's data to patient blood samples to Paris, I could not interpret the results.
Oh.
So that's a practical problem. But I think if you do more, it will get better.
May I ask a question?
Any other point you want to say?
Even the ATP7B peptide, if it's available, again, you'll have it available for newborn screening, and in patients where you don't have definite answers on genetics, it will help. And in terms of treatment, trientine tetrahydrochloride is a good option now. We were reluctant to use trientine dihydrochloride because of the cold chain. It's easier to use the tetrahydrochloride and it's cheaper. So,
Even the cold chain thing has gone away.
Is that?
From dihydrochloride. So it's a lot of it is company versus company. One is promoting against the other. But Univar, it is dihydrochloride. That are also saying now in the new experiments they've done, the temperature is gone.
It's no longer needed.
So why did it do it for so many decades?
Well, because they were only one.
So then, okay. So now.
Competition, so they have come up with.
That's interesting.
Right.
Okay, thank you.
And my conflict is I'm advised to both.
See, actually, it is the pediatric gastroenterology which brought in the trientine in this country with the help of INASL, ISG, and IAP. We could get this drug trientine and also for hepatitis anemia, plus food formulation.
Yeah.
We have got into the struggle with the government of India. Now, I want to just know from you, trientine, bone marrow suppression is there, with depension also, if you have got pancytopenia or your depression, you can't use trientine. And only in where the allergic reactions are there, certain rashes are there, because of D-penicillamine, you may use trientine. That's all.
Yes, so I would still say for us, D-penicillamine is the drug of choice. It's only in those who develop severe leukopenias or a nephrotic syndrome with D-penicillamine where I would switch to trientine. It is not the first drug of choice.
Sadhana,
Or SLE,
I just
yeah.
wanted to ask one question, Dr. Dhawan. You said that there are a lot of issues with the viral vectors delivering the gene therapy. So, what is the issue with the non-viral vectors? That is why they are not developing the lipid nanoparticles and so on and so forth. Is it because of the fact that the dose is expensive, or what? What is the issue?
Efficacy. So they are not that effective, while viral vectors are very effective. So that balance is going on, but I think it's just a matter of time.
Is
It
it
will
possible
change.
to, because the viral vectors are limited by the fact, as you said, in infant livers we can't use them,
No, you can use them, but their
but they're going to
efficacy
die
will
out.
go down.
They
Yeah.
are going to die out ultimately. So we need something which actually is harmless, does the function as integrated into the genome.
No, you can do lentivirus. Lentivirus will integrate,
Hmm.
but then the risk is lentivirus can be toxic. Now, if you remember, viral gene therapy has a very bad history. So the first patient died of adenovirus hepatitis.
Yeah.
Then gene therapy was stopped for 25 years. Then it restarted again with a different vectors now. So there is I think every technology gets a knockback, but with time, I think it gets better. So non-viral vectors, but there are the issue of efficacy is there, but what new challenges they will bring to us, we don't know yet. That's the problem.
you had a question. Please ask. You have a question? No. Just give me one summary on these blockers, ASBT blockers. Where are you actually using in UK?
In UK, I can answer otherwise. Sadhana is the expert today.
No, Sadhana is not sharing.
Yeah, so
There's a lot of information.
in UK, we are only using the licensed indications, like licensed. So we are very much regulated by our health authorities or MHRA. So we can only use Mirelixabat for LHE. Okay, Odivixivab is used for PFIC 1 and 2 or PFIC with itching, but they need to have itching. We can't use. We can, what we call is off license use, means you can use it but without under the license. Because of the cost, our our healthcare authorities are not willing to do it because the cost of these drugs is prohibitive, and sometimes transplantation may be cheaper than putting these patients on these drugs.
Now,
So
what is the indication where you would like to use it? Suppose you had
so
a lot of
allergies.
money.
So allergy is a license indication. Child starts itching, we start it. Okay, PFIC 1 and 2, when the conventional drugs fail, they are not responding to rifampicin, then we switch them to this.
Before biliary diversion. Before
So
biliary
yeah,
diversion.
we did biliary diversion. We still think it may have its role because if somebody's look at the economic model, because some people are using these inhibitors in PFIC1 after transplant also. So that becomes a very expensive option. There's a transplant plus the lifelong cost of these drugs. And there you have seen the paper from Chennai, the biliary diversion, one very good outcome on PFIC1. So there is a data to show, but Western world is agnostic to cost sometime. So they will say, we don't want another operation. Why do you just give them this medication? So it's evolving. I think the cost will go down once with the new drugs come or generics will come out. But for the next few years, the cost will prohibitive the use of this drug. So we can't do it. You can do it. You can get it from Japan or Hyderabad or Chennai somewhere. Yeah. So you can get it. We can't do it. Yeah. You can use it. Don't tell anybody. Have 50 patients, 20 patients, and publish in New England Journal of Medicine. It will change everything. So do that, because if you tell everybody, then you regulatory authorities won't let you do it. And the company, if they find out they're using a cheap drug, they will be saying, "Oh, why are you doing it?" So just do it quietly if it's safe. I'm told by my colleague who is expert of cholestasis, he said that is the best drug to have if you can have it. Yeah, yeah, that's what he said. Japanese use it for constipation. Okay, why don't you use it?
So we
I'll take few tablets.
thank you very much. I thank all the speakers and the audience for this wonderful session, and I
somebody does this trial without, not a trial, it will be named patient history. That's how you do it.